It's that piece of if you can't see the wound, it's not there. Like, it's not true. Just because someone looks fine, just because, and especially we know women with ADHD, that masking, you know, that almost perfectionism, I'm fine, and they're inside, they're just completely tense. It's a real disservice. I mean, they say it's about 10% of children, and depending on where you look, 4 to 5% of adults, isn't it? So that's an awful lot of people that we're not diagnosing. I would argue that we're underdiagnosing it still.
This podcast is part of the GK Media Studios Creators Network, helping people tell their stories. Become a storyteller today and learn about our podcaster network at gkmediastudios.com.
Welcome to Psychology with a Sparkle. I'm your host, Dr. Denise O'Dwyer, and this is episode 13 and the first episode, season 2 for 2026. Today, I'm thrilled to have Doctor in the house, Dr. Nina Byrnes. Some of you may recognise Nina, as I did when we were at the psychology conference, from her work with Virgin Media, what was TV3, Doctor in the House, and formerly Health of the Nation with RTE. Nina is a medical doctor who graduated third in her class from Trinity College with an honours medical degree. She's the founder of and practising doctor at Generation Health Medical Centre. And you've got clinics in Monkstown and Castleknock, Nina.
I do.
Dr. Nina has 30 years of professional healthcare experience, having worked across the globe from France to Australia, as well as a very prestigious Cleveland, Ohio clinic in the US. Nina has postgraduate training in clinical psychiatry and firmly believes, as do I, Nina, in the interconnectedness of mind and body health. Nina has a specialised interest in adult ADHD, and she and her team at Generation Health lead out in evidence-based assessment and management of ADHD. Dr. Nina is a regular contributor and medical commentator across various national media, TV and media platforms. She is the author of Your Health Matters. She's wife to Dean and mum to Alex, Luke and Ed. So welcome to the podcast, Nina. Delighted to have you here.
It's great to be here. You know, I always think when you hear those sort of things read back, you know, you never think of yourself and what you've done, do you? But I think
very accomplished.
My proudest
career.
achievement is at the end of that list, I have to say.
Yeah, which is lovely.
Yeah.
So before, I think the main focus of this, Nina, I think I mentioned to you before we started, I put out an Instagram poll to ask people kind of the areas of interest that they had for the upcoming episodes for season 2. And ADHD came out as one of the, you know, strongest ones in terms of subject areas people wanted to dive into. So that'll be kind of the main focus of our conversation. But for the listeners and for anyone who maybe doesn't know you, could you introduce yourself and let us know a little bit about your background and kind of what led you into what you're currently doing with Generation Health? And because I know you have a lot of variety in your history.
Yeah, you know, I've been asked over time to describe myself. One of the things I described myself a long time ago is as a social hybrid, and someone laughed at that. But I grew up in a house, and my dad is American, he's from Boston, and my mum, there is a Galway connection, my mum's actually from Carrow. So so I grew up in a house where there were people from both sides of the Atlantic, so I always think there was a real influence in both of those. And we moved around quite a lot when I was younger. So we lived in France for several years from when I was 2 till I was 5. And then we moved to the States from when I was 13 till I was 16. And then I went to Australia, lived there for a year after college. I spent a year of college in France. And so I think that experience of different people, different cultures, moving around kind of moulded my interest, I think. My mum was a nurse. So when she had a nursing home, we were younger. I think that's where health came in, and I always wanted to be in health. I remember following the nurses around in the nursing home, you know. When I think back now, they must have hated it, but I used to literally follow them around, you know, going into the patients. And I remember very early on, you know, saying to my mum, I want to be a nurse. And there's some photos of me in like doctor kits at a very young age. I do remember her saying, you know, why don't you be a doctor? And I think it was the first time I realised girls could be doctors, I think.
Yeah.
So I always wanted to do it. And when I went in, you know, when you start in college, I always say to medical students, people always say, when you're in school, what do you want to do? I want to be a doctor. As soon as you're in medical school, people start saying, what do you want to specialise in? You know, you're barely started.
Yeah.
And I always thought I was going to do cardiology, actually. So I loved cardiology, absolutely loved everything about it. And so when I qualified in medicine, I did a medical scheme, and that's how I ended up in the Cleveland Clinic, which is obviously one of the most prestigious cardiac hospitals in the world. And I worked there, and I loved it. But every specialty I went into, I loved it, and I went, but could I do just this for the rest of my life? And the answer was always kind of, could I do just hearts? Could I do, just kidneys? I did some oncology. I absolutely loved cancer care. And so, but then I realized more and more, and I think Cleveland definitely sowed the seed on that. When I was in Cleveland, they were starting up their whole lifestyle preventive health area. And some of the people I worked under there were very involved in cardiovascular risk as opposed to treating cardiovascular disease. And so I came back from Cleveland and I finished my second year of SHO scheme in Dublin. And I was at kind of like, you're at that decision where you're going to, are you going to go on to the hospital medicine? Are you going to be a reg, or what are you going to do? And I decided I really didn't know. So actually I got married then. And so we went to Australia for the year, and I worked as a registrar in Australia, did a lot of ICU actually there. And then I really focused, I was thinking, God, actually, it's not so much treating the disease that really inspires me. It's how do we keep them well? So even with cancer care, I was kind of looking about, how do we catch it early? How do we prevent it? And so it was a really conscious decision to go into general practice. I remember sitting down one day and writing down the pros and cons of staying in the hospital or doing general practice. And general practice really ticked the boxes because I could really be involved at a community level and preventive health. So that's how I moved into that. And then when I started in GP, one of the things you don't think about, but you're in a hospital, you have a lot of control over someone's health. You prescribe a diet, you prescribe a medication.
Sure.
They're going to be given those pills, they're going to be given that food. But when you're in the community, the communication piece is so much more important, and you have to bring the patient with you. You have to convince them that the advice you give is of value to them, because they're going to walk out that door and you don't know if they're going to take the medication. Or so, communication, mental health really became a huge piece. And actually, when I was doing my my GP scheme, I did 6 months psychiatry, which was normal then. And I loved psychiatry. And I remember, sitting down, I was in St. Pat's, and they had a great team who were really supportive of GP trainees. They very much, didn't do the same stuff with us as the psych regis. They were very focused on us learning what we needed to know as GPs. And I remember sitting down with Prof. McKeown, who was the master at the time. Or not the master, he was the head person in their masters, the maternity hospitals. But they tried to convince me to switch to psychiatry because they said, you have an interest in this. I can see that you enjoy it. And again, I went, yeah, but I don't know if I could do just psychiatry for the rest of my life. But I definitely sowed the seed of how mental health was so important in everything you do, and in bringing people along and convincing them that to make the changes, but also to realize that how if they didn't have good mental health, they didn't have good physical health.
Yeah.
And so as I kind of moved along in general practice and worked in other practices, I suppose that interest in mental health just grew stronger. And that's when I did then the postgraduate diploma in psychiatry. And then ADHD was sort of always in the background. My husband's okay for me to say this. He has ADHD. He was the very typical child diagnosed, bouncing off the walls.
Okay.
That very typical piece. So I'd always lived with that, and I'd always had an interest in it because I'd seen his struggles, and we had very much tried to understand and manage it. And I would have had quite a few patients maybe who would have been discharged from psychiatrists or seeing psychiatrists that I would have supported in that. And so then when I realised that there were some GPs doing ADHD, it just felt like a natural progression, to be honest, something that I really wanted to be involved in. The timing sort of worked well. We look after student health in IADT, which is an art college, and they have a huge neurodivergent population. And as you know, Loretta was there, so that's how we met. And they had this huge group of students who were seeking assessment, seeking diagnosis with really no access whatsoever. So I went, when I saw that you could do the diploma, I was lucky to follow the training, and really the big hurdle was getting insurance over the line.
Okay.
So that took a while. So we did that, and I'm very lucky. My supervising psychiatrist, which was a necessity, is Alan Murta, who's really kindly been in that position now for over a year and is extremely supportive. So that's sort of the journey to how I'm here. That's how I ended up being interested in that mix between physical and mental health. And I think, you can't take the head off someone. I think actually I was listening to one of your podcasts. What did you say? It was Gabor
Mate.
Didn't he say about the head and the body?
Yeah.
But it's so true.
Yeah.
And especially in general practice, I think if you're just looking at the person coming in based on the disease they have, you can't be a good doctor, because you have got to not just look at the disease they have or the infection they have, you have got to consider the impact on them, because they're not going to walk out the door with any kind of therapeutic benefit if you haven't done that. It's my personal opinion.
Absolutely. And like, it's lovely that you have that holistic focus, Nina, and I suppose that came across very strongly, which is something else I wanted to ask you about, which is your media work, where a lot of people, where I recognised you from, Doctor in the House. So you're still involved in kind of media as well, aren't you?
A little bit, yeah. I mean, I've always said I'm a doctor who does some media, not a media doctor. It's not quite the same thing. So I'm very much, the day job is I am a doctor, first and foremost. But, the first show I did was back in, I think it was 2010. I really thought at the time this would be something I would do for a year or two, but so it's still to be doing some, 16 years later actually is amazing. When I've dipped in and out, I don't tend to go looking for it. Noel Kelly has been my agent for a long time, and they would approach me with things on and off, and it's great, because anything I've said yes to is something I want to do or I really enjoy. I've been really, really lucky that the two shows I did were just great teams. I learned a lot from them. We genuinely got on well. I know it sounds cliche, but honestly, everyone on those production teams and everything, they were just fab. And I'm still obviously in touch with some of them. So now I do radio now. So I do every second Monday, I'm on Lunchtime Live with Andrea Gilligan in News Talk.
Fantastic.
And I really enjoy that. Radio is a lovely medium.
Yeah. Yeah.
And I was with, when Ryan Tubridy was on 2FM, I used to do the same thing kind of every second week in there. And your radio just feels really personal, doesn't it? And I suppose podcasts are an evolution of that. It's very personal. You don't have to do all the hair and makeup and stuff that you have to do.
Absolutely.
And it's just like having a chat. So I enjoy it. During COVID, I did a bit of the kind of panel shows and stuff, which was great to do. And again, Virgin Media have always been very supportive of me, because they used to invite me into the Tonight Show a lot. And RTE would often invite me into their panel shows as well. But I felt after a while on that, I was just giving out a lot, You felt like you were making a lot of kind of political commentary about health. And I felt it just didn't sit as comfortably. I like kind of the patient-facing piece, the talking to the patients more, I think. But, every now and then there's something I feel strongly about. I'm more than happy to talk out about it. But
and you're involved in print media as well, aren't you? With the
So I was.
Yeah.
Not anymore. So I was with what would have been the Sunday Business Post I started with. And then I used to do a column with them. And then I moved to the Independent for quite a few years. And then out of that, I wrote my book. I'm not a natural writer. Yeah, I really admire people who are really good at writing. It's not something that comes naturally to me, I have to be honest.
Okay.
Yeah, I struggled. Like, it's hard. It's very hard work to sit down and write.
Well, especially when you're working full time, it really requires that, element of discipline to kind of find the time and to...
Yeah. Like writing the book, I had to literally approach it like a project, map out the chapters. I was doing one chapter a week.
Everybody does.
Yeah, no, and I said that. I've spoken to authors and they said that. They do that. And I really, really admire print journalists. I think, they probably don't get the credit they deserve. The amount of research that goes behind putting down that column or that article and making it sound fresh and original every week. It's a real talent, to be honest.
Yeah, absolutely. Fantastic. So moving on then to kind of the ADHD side, Nina, I suppose as a psychologist, we were just saying before we started that it's, seems to be becoming, there's so many... It's a very common presentation for people, especially in recent years. And I suppose what we look out for are, the difficulties with sustained attention, difficulties with concentration, that impulse control, and distractibility, and, hyper movement or, inability to kind of sit still. From a medical perspective, what are the differentials that you look for in terms of diagnosing ADHD?
So, people will come in, I suppose there's two kinds of people that I see. So obviously, since I started doing it, most of the patients who come are word of mouth. So there are people coming to me a lot now that they think they have ADHD. So you're starting from the point that they've already recognized a lot of the symptoms for whatever reason. And it's funny, people say everyone thinks they have ADHD now. I don't know if they do, but a lot of them are coming in sort of, they've seen it on social media. But what I find actually quite a few are that they have a child who's neurodivergent, and the child is going through the diagnostic process and they're answering the questionnaires and they're identifying with an awful lot of the symptoms on there.
Okay.
And they're going, oh, that's me. Maybe I should explore it. But then what I also find is that I have patients who are coming to me for other reasons. So it can be some physical reasons, a lot of stress, a lot of anxiety. And as I'm teasing out the symptoms of those conditions, in my head, I'm going, well, actually, this ticks a lot. So I'll actually raise it with people sometimes. I'll say, have you ever thought about ADHD? And some of them have. And they've written themselves off because they weren't, because they did okay academically.
Sure.
That's the one I'll always say, but I didn't have difficulty in school. And there's this impression out there that somehow if you did well in school you can't have ADHD, which is just so far from the truth. As you know, there are a lot of very high achieving, particularly women, who become workaholics, perfectionistic, overworking, and they're actually classic ADHD when you break down into it. So I do bring it up with people now, and so it's kind of the two approaches. So the differential you're working through, I suppose, is all the various other psychiatric conditions and psychological impact. So when patients first come, one of the things I do is this sort of a pre-assessment process where there's a number of questionnaires, and what I'm screening for is anxiety, depression. We do an autism screener.
Yeah.
Not that it's a differential diagnosis, but they travel very commonly together.
Yeah.
And then trauma. We do a trauma questionnaire.
Okay.
And the thing is, it's pretty rare that you're going to find someone that doesn't have some of that in there. So I find anxiety, if someone hasn't been diagnosed into adulthood, anxiety is commonly there.
Absolutely.
And it's kind of hard to tease out. So what I'll often say to patients, if they've scored quite high on anxiety and we're exploring it, I kind of say, once I'm sure that the anxiety isn't so severe, I can't treat the ADHD, I say we're going to treat the ADHD, we're going to see where we take that, and then we're going to explore the anxiety again.
Okay.
And see where we are, because sometimes you do need to treat both.
Sure. Yeah, absolutely. And then in terms of the kind of distractibility piece versus significant, clinical diagnosis of ADHD, how do you make that?
So obviously, you're doing the DIVA interview, and you're not just asking the questions, you're delving down a little bit into the symptoms. So, and I always kind of, again, I'm sure you're familiar with the interview. It feels very formal. You've got this sort of form in front of you. You have to go through these very formal questions. And I always have this little speech that I do, but it's very true. I'll say to them, look, this is an interview, not a quiz. Okay, so I'm going to ask you questions, but there's no right or wrong answer. And actually, I want you to tell me stories, because storytelling is a great way to get the symptoms out from people with ADHD. And so you're kind of exploring each symptom in more detail. So, and you want, it can't just be distractible in one area. It can't just be that, I'm distractible if I'm tired or if I have a lot going on. And, in one way, I suppose, again, there's the two groups of patients. The patients I know well, the patients that are patients of mine, I kind of know their background. I know maybe it's going on in their life. I know, are they really just in this phase now, but actually they haven't been like this before. Obviously, the collateral is a really important piece of it all. Talking to someone who's known them, so that this distractibility isn't just at menopause or just because they're a new mom. Exactly. So that they're, they have a baby brain or something. But I suppose you have to, I do give people the benefit of the doubt a lot in it, just to see their impact and how they're coping and how they've coped over different periods of their life, and exploring those periods. So if you're someone maybe who has come in menopause, you're exploring what was life like for them maybe when they first had children or when they've had change in their life. Because I think obviously anxiety, distractibility can come with overwhelm. Yeah. Is it overwhelm or is it ADHD? Yeah.
Okay. And then there's been, I suppose, quite a bit of controversy in terms of the medication side, particularly for children. Yeah. And I think in the States they've kind of nearly moved away from the stimulant medication. What are the differences actually, Nina, between stimulant versus non-stimulant medication?
Well, so stimulant medication is the first line medication in ADHD, but it does get a lot of bad press because these are drugs, I suppose, they're kind of scary. They're a stimulant. One of them's amphetamine based. And when people hear words like that, they think addiction, they think abuse. But the science would strongly stack up that these drugs are not addictive in people with ADHD, and they can work incredibly well for some people. But the thing I always say to patients is, I say, look, we diagnose your ADHD based on your symptoms, but the decision to treat is based on the impact. So you can have ADHD, you could have all the symptoms of ADHD, but if it's not impacting your life, you don't need medical treatment.
Yeah.
The advantage, I think, of the stimulant medicine as well is if it's suitable to people is that obviously they don't have to take it every day. And in fact, you'll find most people with ADHD don't. In fact, a lot of them forget to go get their prescriptions. So, I don't worry about the addiction, even though people talk about it. The non-stimulant you have to take every day. A lot of these, when I'm describing them to patients, I'll say, actually, some of these are older blood pressure tablets. They're cardiovascular tablets, the alpha blockers. They work actually. They slow your heart. They reduce your blood pressure, but they have a calming effect. But you do have to take them every day. Some of them can make some people a little bit sleepy, but they can work really well for some people. So the
stimulant ones are taken as required, is that?
Yeah, you don't have to take stimulant medicine every day.
Okay.
So that's actually a huge advantage in children taking ADHD medicine, is if their real pain point is school or that, they can just take it on weekdays and not take it on weekends, not take it on holidays. And you do not find ADHD patients crawling the street looking for their stimulant medicine because they're not getting a buzz off it. If you're getting a buzz off it, you don't really have ADHD to a certain extent because it's a calming effect. So I have to be honest, I think the medication gets a lot of bad press. There was some stuff in children about, maybe not growing as much as possible and that. But then, I've looked at that, and some of the studies would say that no, they catch up and they reach their normal height. And again, I think the long-term impact of untreated ADHD, there's mounting evidence more and more that untreated ADHD has a lot more problems than treated ADHD. So in some ways, I think not everyone needs medication. I think it's one arm of treatment. I think that's important to say. But I also think that it gets an awful lot of bad press because it can be really life-changing for people.
Okay. And then in terms of, management of ADHD in the absence of medication, do you work with patients like that as well?
Yeah. So I always say it to patients when they come in. I always, first of all, ask them, why they've come to Generation Health for their assessment, because people come for different reasons. And I do the assessment over about 4 or 5 appointments. So it's not a kind of a ring, book in, have your appointment and you've got your diagnosis. I like to kind of take my time, get a sense of the patients, let them come to terms with the diagnosis, be there for questions. So I say to them, I'm a GP doing an assessment and I can't take my GP hat off. So it's a whole person piece. So actually my first appointment is very much just going through a medical history, seeing why they've come to wanting to be assessed for ADHD. And I kind of say to them, there's 2 reasons I do that. The first reason is to make sure that they're suited to progress in general practice. There are some people should be seeing a psychiatrist to be assessed. I feel strongly about that. There are some people, if they have complicated psychiatric histories or lots of other stuff going on, they really should be seeing a psychiatrist who is an expert in that area. But then also I'm thinking ahead to, if we are going to prescribe medicine, can we prescribe it safely? So with my background interest in cardiovascular disease, I very much do a cardiovascular risk profile. And the ADHD medicine is safe, and it's even people with blood pressure, their blood pressure is controlled, they can take it. But there are a number of cardiac issues. So things like cardiomyopathies, rhythm disorders. And if you think there could be a structural or a congenital heart issue, you'd have to be very, very sure that their heart is healthy. So I've had a few people I've referred on to cardiologists, actually, which is some of the questions I ask in that. The majority of them cleared by their cardiologist before I prescribed medication. But there were 1 or 2 actually that, we found things that they wouldn't necessarily have known, and they've gone down the pathway of having the heart sorted rather than the ADHD sorted. So I do a whole person approach. And then once we diagnose them, one of the other things I really do talk about is nutrition. So to really oversimplify it, I kind of say to them, look, any medication we prescribe is hopefully going to boost dopamine or your neurotransmitters, noradrenaline in the brain. But I say you've got to be making them in the first place. And, nutrition has a really important role to play in the making of our neurotransmitters. So it's a kind of a seesaw piece, isn't it? Now that's really simplifying it. I'm sure if there are any pharmacists out there or neuropsychologists or neuropsychiatrists, they're going to be going, she's really oversimplifying this. But it's in a way that's understanding. There's 2 sides to it. You've got to have the body functioning well, be metabolically as fit and healthy as you can be. So there's no diet for ADHD. I always say this to people. The only evidence of diet in ADHD is a Mediterranean diet, which is the diet we should all be eating. And we all know it. I always say, there's a huge drive right now for people to look at labels on things and look up the list. I had a home ec teacher that a long time ago taught me that if you're reading a list of ingredients on your food, you probably shouldn't be eating it. I mean, I think it's a really simple rule to live by. If you actually don't understand the name of something you're eating, you shouldn't be buying it in the first place. You shouldn't have to look up what's in your food. So it brings us back to that, unprocessed, healthy diet. Healthy fats are a part of the Mediterranean diet, and there is some science behind that in the brain. Our brains are, I think someone told me before, they're about 80% fat, so healthy fats are really important for the brain. And then I do recommend some supplements, and I always make a point of saying to patients, they're supplements, right? This is not to replace the diet.
Sure.
But unfortunately, in where we live, even with the best of intentions, even if you think you're buying fresh and healthy food, we're not all getting the nutrition we need. And so, I do bloods on all the patients. Very, very commonly, I'm going to see some nutritional deficits there. In fact, in nearly all of them, I'm going to see some B vitamins off or some iron off. And obviously, I talk first about diet, but I do have some supplements that I recommend. And even to the point that my husband, I think he's sick of my projects, but he's on board with this one, is I was buying all kinds of supplements at home, trying to kind of put the perfect match together. And I can't find it. So we've actually gone as far as to now we're looking at formulating. For the last 2 years now, but we're actually approaching companies now to get what I think is the perfect mix up. And again, it's just about, you don't need a mega dose. You just need something to supplement a healthy diet. This is about supporting. And then I talk to them a lot about kind of wellness. And, this is what I love. I think part of why we connected on that was the whole mind body essence. So exercise is treatment for ADHD, but you don't have to be a gym bunny. It just means move.
Exactly.
And like the science to say that people with ADHD can focus better. That's why they say maybe walk around when you're on a call, get up, get down. So I talk to them about moving. I'm amazed how much time I spend teaching people how to breathe. Like that square breathing. People don't know how to do it.
That's what happens though when we become anxious. We forget to breathe.
We all do this.
Yeah, exactly.
And so I, get them to close their eyes and, I'm sure you've done this before, picture a square because the holding on the top and the holding on the bottom, and I'll often do it with their blood pressure and they'll see the blood pressure might be up, and as they do that, it comes down.
Yeah.
And of course, we know there's a huge amount of research into the vagus nerve now and how that involves in that, and I kind of explain that. So, so it takes a few visits, but I'd like to think that we do it from a very kind of holistic whole person approach.
Which is amazing.
And then, so it's actually at the very last visit that any medication gets prescribed. So at that 2-hour interview in the middle, we do the whole interview, and that's where I do the whole nutrition piece. And I sort of say, I want you to start all that now if they're not doing it. And then you're going to see me back in a few weeks. And it's sort of like, so when we start the medication, I've got them to that baseline of what's their good baseline. And then I know where we're going from. And I find if you do that, actually, a lot of people don't need mega doses of medication. They really don't.
Makes sense.
Yeah.
So from an evidence-based perspective, Nina, which one of those, or is it like that kind of the myriad of all of those different lifestyle factors, or would you say that diet is kind of the main one outside of medication in terms of, assisting with ADHD?
It's hard from like the adult studies, but I suppose there isn't. I suppose the important thing I say is there isn't a diet for ADHD. The Mediterranean diet is the one that has the strongest evidence for ADHD, but honestly, it's the strongest evidence for health in general. Protein is something I do talk to people about. But again, I think if you go and if you were to read a lot of the stuff on social media, they're talking about mega doses of protein. The World Health Organization recommend 0.8 to 1.2 grams of protein per kilo body weight per day per person. So this is a standard recommendation for everybody. I kind of sit at the 1 milligram because it's just a nice number. But a lot of people, when they sit down, they're just not getting that in their diet. And I sort of say to people, look, those standards were set by the World Health Organization, maybe looking at, malnutrition in Africa and certain countries, at the basics that our body needs. But we're living in a world where we have lots of access to food, but we're not necessarily getting the nutrition we need. And so I actually hate the word diet. I love the word nourish. And I say to people, the food you take should be of value to you. You should think about that because it is the building block. And protein is, we know it's the one nutrient you can't make. So if you live on nothing but carbohydrate, your body can't make amino acids. Whereas you can make energy from protein. But again, it's about balance. And I always say, I'm not saying a keto diet. I'm not saying go off and eat nothing but protein. What I'm saying is you need enough protein. And unfortunately in Ireland, our diet is probably too high in carbohydrates, I think, for the majority of people. And that's seesawing, so when you were saying evidence-based, I've gone off point there. But what we're saying, it's not even just with ADHD. I think the evidence is mounting from nutrition and mental health, neurodiversity, neurodegenerative disease, is that insulin resistance is definitely playing a role in that, and the inflammation that it does. So it's that high carbohydrate, sugar spikes, insulin going up, affecting your liver, affecting the way your body uses nutrition. All of that evidence is mounting that it drives inflammation. And then there's this whole piece looking at inflammation and health. And that's the piece that I find
and that it
fascinating.
Affects your cognition. It affects, everything, your mental health.
Well, the way you say it, and again, so AI obviously is great. I think AI is great in medicine. I was at a talk and someone said, AI won't replace doctors, but it will replace doctors who don't use AI. I do believe that. So if a patient comes into me and they've done their research, I don't shut it down. But so there are a couple of actually really good medical AI apps now that, really they use, like the one I use is called Open Evidence and it's approved by the New England Journal and stuff. Anything that's on there is properly peer-reviewed stuff. So when you're trying to look at evidence, but there's these smaller studies looking at insulin resistance and diet and inflammation. And the way I say it to patients is, when I started as a doctor and my interest in cardiology, when I was graduating, we knew that inflammation caused arthritis. So we talked a lot about rheumatoid arthritis and we were using drugs that reduced inflammation. And by the time I went to Cleveland, we were already treating cardiovascular disease. We were giving people aspirin and we were saying, oh no, well, inflammation in your arteries is making your arteries stiff and it's really bad. And now we're treating cancers with drugs that are not that different to what we were using initially in arthritis. These are immune modulating drugs. And so the science is really going to that stress causes inflammation. What's the stress? So the stress can be the environment. It can be your diet. It could be an illness. It can be psychological stress. But the result in the body is it affects our immune system. And then that shows in different ways. And I think that's really where the research is starting to go. I think we've probably come along hugely in the last 5 years. I've no doubt in the next 10 years we're going to know a lot more about this because there are big institutes looking at this and the brain. And where we know inflammation affects the body. I mean, it's kind of laughable. I think I said this at the PSI conference. Like, how did we ever think that inflammation stopped at our neck? That it affected everything below the neck, but no, the brain was fine, wasn't impacted.
Absolutely.
It just doesn't make sense, does it? And I think we're looking at inflammation from the point of view of Alzheimer's, Parkinson's, all those, MS, all those neurodegenerative diseases, and mental health. And so I think that whole person piece is going to become even more and more important.
In terms of kind of across the lifespan then, Nina, like ADHD, as it presents from childhood and the progression into adulthood, if people, go to somebody like yourself or go to one of your clinics and they get to a stage where they're managing their ADHD, is there kind of a decline in symptoms or what way, over the lifespan? How does somebody can they effectively be treated in terms of their management of symptoms, or can they kind of go off and do their own thing, or do they need to kind of be checking back with you every so often, or what way is that?
So again, when I'm talking about treatment to people, again, it comes back to the impact piece. So you're making the decision based on impact. And when I'm looking at the impact, you have to have impact in more than 2 areas of your life. I mean, that's the criteria for treatment. But then when I'm talking to patients, I'm looking at where the impact is in their life. And so that varies hugely, So, I mean, I can think of a couple of patients who are massively successful in their career, right? So work's not a problem for them. Because we know people with ADHD can hyper-focus on stuff they love. So they're flying it. And particularly I can think of kind of, you know, two women who are very successful, very high flying careers, love their job.
Yeah.
But it's a disaster at home. They can't organize anything outside. They're constantly, as they said, you know, overwhelmed, running on empty at home. So actually they take the medication more at weekends and that kind of thing, rather than in the days where they're maybe 10-hour days at work.
Yeah.
So you're looking at the impact when you're treating people, and then they're taking the medication based on that. Obviously, when they start, yes, there's that initial titration period. And I start low and I go slow. So there's a bit of seeing people back. Once you get them to where it's working for them, then you can let them off. I mean, the longest prescription you can do is 3 months. But ultimately, the goal is to get someone to where you only have to see them once a year.
Sure.
You know, they might have to ring in for their prescriptions, and that's just the prescribing rules. But you do need to see them once a year. You do have to do a kind of a longer appointment, review the impact again, and decide if treatment is still warranted. So there are people who might need a treatment at a certain period, and then they might be okay for another few years, you know. And so you have to kind of just work with it. And, you know, one of the things I love about it, and I say it to the patients all the time as well, is, you know, yes, it's a science, right? Yes, we're doing evidence-based medicine and we're looking at the science. But I always say medicine, despite being a science, is a human science.
Absolutely.
And no two humans are the same. So each approach has to be personalised. And that's not just with ADHD. I think you have to just know the whole person in front of you and decide what's the right treatment for them. So yes, you're using the evidence base in the back. Yes, you know, even on blood pressure tablets, like I know certain people of a certain age should get a different drug first line. But then you also know the person. And, you know, in the same way, you know, like certain antibiotics are first line for certain things. You always have that in the back of your head. But then, you know, maybe that person's a bit forgetful and actually taking a drug 3 times a day is not going to work for them. Or, you know, you've got to be aware of that and work with the person. And I don't think ADHD, certainly the way I approach it, is no different.
Sure.
Yeah.
Yeah. And I suppose on that note, like oftentimes with anything, be it ADHD, anxiety, whatever the presentation is, sometimes we can, you know, people can focus a lot on the weaknesses or kind of, you know, the drawbacks that it brings to their life. What have you noted, Nina, in your practice are the strengths, you know, some of the positive things about it?
Yeah, no, and I'm really glad you said that, because we don't talk enough about it. I think an awful lot of what's out there is people posting their difficulties in life with ADHD. But you know how many people are out there that ADHD, it's a very overused term, but is their superpower. Yeah. You know, and I've one lovely patient who's massively successful entrepreneur. He's succeeded and failed in a multitude of things. But you know, he's had a great life because of it. And one of the things I find talking to, especially in the interview, when you're asking them back about their life and you're asking a lot of questions, you're going back through their life, is how much we smile in that, how many memories that come up for them are not sad memories. They're very happy memories, things that they've done, maybe taken some risks, but actually the risks brought them to where they were. Maybe, you know, we know that a massive amount of entrepreneurs have ADHD because they're not going to think through everything, all the problems, all the worries before they do it. They're going to go with their instinct, with their gut. And that's not a bad thing, you know, and I think... So again, you don't want to kind of numb every symptom of someone's ADHD. And if it's not, and that's why the impact piece, I think we don't talk enough about. People talk about the symptoms all the time. Yeah. But the treatment is based on impact, and you've got to look at the impact on your life, where it's impacting you. And is it something that you need to change? Because there are people... You know, I think maybe would we be where we are in the tech industry with the world around us the way it is without people with ADHD, because they were the risk takers, the innovators, the pattern that people with ADHD are very good at seeing patterns, as we know the people who are autistic are, and maybe seeing things in a way other people didn't, that different perspective. You know, when I think back through history, they've named lots of people who they've decided had ADHD. I guess we didn't have the luxury of diagnosing them, but... You know, where would we be? Yeah. You know, and I think, if you looked out to Silicon Valley and all those tech startups, a lot of those, when you look at them, you'd think, well, they probably have ADHD. And some of them have come out publicly and said them.
100%.
I know Richard Branson has spoken publicly about, you know, having ADHD. And so I think, and you know, it's funny, since I've started treating it and talking to people and I kind of say, people with ADHD are fun to be around.
Yeah.
I always think, I love the Minions. I don't know if you like the Minions, but I love Gru. I think he's just this fabulous sort of, and he talks about zinging with people. Do you remember in the one where he had a girlfriend and he said they zinged? I think people with ADHD, you kind of zing with them, don't you? You get that little spark that you just feel, and they're,
they're
they can be
on.
Yeah.
And then I suppose some of the controversies or myths around ADHD, which you and I both know there are many. But what would you kind of say to that? Yeah.
Had you anyone specifically, or I suppose the medication one is the people talk a lot about, isn't it? That
or that it's overused and there's no such thing, and
that drives me crazy. I find that really unfair, because it's that piece of if you can't see the wound, it's not there. Like, it's not true. Just because someone looks fine, and especially we know women with ADHD, that masking, that almost perfectionism. I'm fine. And they're inside, they're just completely tense. It's a real disservice. I mean, they say it's about 10% of children, and depending on where you look, 4 to 5% of adults, isn't it? So that's an awful lot of people that we're not diagnosing. I would argue that we're underdiagnosing it still. And, one of the things I say is, so when people come in, when you're the collateral, you're talking to family, but I often say, if you have any old school reports, can you bring them in as well? And I'm always amazed at how many people actually, their parents have kept their school reports. It's so lovely. Parents are so proud of their kids.
Yeah.
But consistently reading on those is, written work not reflecting participation in class. Like, they like these kids, right? So this is very enthusiastic in class, could focus more on homework, needs to concentrate better, could achieve more. And honestly, part of me says, should I be out in, primary school teacher training saying to the teachers, if you're writing in a school report, could focus better, needs to work harder, smarter than their grades imply, could pay more attention, or things like bit of a daydreamer. Please, these kids likely have ADHD, and you should be raising it. You should be talking to people about it.
Yeah. But there still is that whole gap in knowledge, though, isn't there?
I think they are. I had one patient actually who came in for assessment who is a primary teacher, and I had spoken to her about it, and she said they are getting some teaching now, but again, it is also down to them. They can do courses in various things, but they do have to have that interest. But you do still see, and the teacher going, could work harder, needs to apply themselves more. And a child with ADHD, when I see it in adults all the time, and when I'm talking to them, some of them get quite emotional, because they're like, I was trying so hard to pay attention in school. I was trying so hard to be that good kid who was able to listen to the teacher, who was able to remember stuff. And they get quite upset, actually, because then they're going, they all thought I wasn't paying attention, I was daydreaming, and it took everything out of me every day to sit up and try and listen in that class. And it drives anxiety.
And that's traumatic. Like, if they're speaking about that as adults, that means it had a hugely traumatic impact on them as children, And
the trauma piece is interesting as well, because you have people then who say it's not ADHD, it's trauma. And I do a trauma questionnaire on all the patients. And obviously on that, you're looking for, is there PTSD? You're looking at their emotional dysregulation. And again, there's a huge overlap between the two of those. But I can't remember who said it, but I think it was at a conference I was at last year, and I can't remember who spoke about it, but they spoke about trauma. And I thought it was really good the way they said it. They said, so there's a huge overlap of symptoms between unresolved trauma and ADHD, but the sense is, ADHD is clearly a genetic condition. We know that. You just look at families. Every patient that comes in, I'll say to them, if you were to look at one of your parents, which one has ADHD? And none of them hesitate. Okay. Like, within a second, they've told me which parent they think has it.
Right.
So, they can look at it. Everyone can look back at families, look back at patterns. But what was said was that when people with ADHD experience trauma, it has a much more profound and long-standing impact, because in the back there's that rumination, there's that overthinking, there's that kind of physical response. And I think that's a really lovely way to look at it is, so if you think that, that always being told you're daydreaming, not paying attention, that you're just not doing as well, a lot of siblings will end up being compared to their siblings and really feeling that, why can't I just be like, Sarah or my sister or whatever, because I can't do what I have to do. That is a trauma. And that sits with them. And of course, they're going to have symptoms of trauma, because people with ADHD have struggled And it's the same with any neurodiversity, because you see it in autistic patients all the time. They have spent their whole life trying to fit in.
Yeah.
Why can't I be like everybody else?
Absolutely.
And if you've done that all your life
Yeah.
and you've made it to 30 or 40, yes, you're going to have symptoms of trauma. And I think it's a complete disservice to say to people that's not trauma.
Yeah.
That's not ADHD.
And that's why it's so important that we do work from a strengths-based model.
Absolutely.
You know, that you're not
I totally agree.
looking to see the deficits and zoning in on those, that you're actually pulling the great strengths.
And, I look at my husband as poor Dean talking about it. But he's incredibly creative. He's very artistic. And like, he was that classic in school, put outside the class because he was disruptive, couldn't pay attention. I mean, really, I almost get angry when I feel about it. He had one or two teachers who were very good, but and I'm saying that, he would say himself it wasn't easy for the teachers. He literally couldn't sit still. But that whole creative piece, the medication didn't really suit him because he's very creative.
Yeah.
So, he liked the creative mind. It dampens that a little bit.
Yeah.
And in IADT, I'm acutely aware of that because these are arts students. These are students in film and arts and media. And I always kind of, what I say to them and I say to all the patients is, what do you want the medication to do for you? So we're not looking to, we're trying to tailor it.
Yeah.
And I'll say to them, look, we might not push the dose up to suit all of this, because if we push the dose up and we hit that symptom really high, it might take away from the positive piece you have. So I kind of say medication isn't going to fix everything, and it's just about this balance, but we don't want the essence of you gone. We want you to feel like yourself, because you don't need to be someone else.
No.
And that's the other thing. I think some people feel that they suddenly need to be somebody else, and they don't, because you are who you are.
Absolutely.
And there's so many lovely parts to the personality of ADHD. They're enthusiastic. They're very loyal friends. They enjoy life. So it's important that you keep the essence of them as well.
No, absolutely. And I think that's similar as well, Nina, when it comes to even, antidepressant medication, because like that, I'd have a number of clients who would talk about like that. They just take themselves off the medication because it completely numbed their emotion completely to the point of, just not feeling anything. And I think particularly for people who are sensitive in nature, that's not a good place to be, where you feel that you're being numbed.
Yeah. So, psychiatric medication, and I don't want to knock it because it can be life-changing for people. And I think it is so important that if you've been prescribed but you should feel comfortable having that conversation. And yes, some patients come in and they're like, I feel a bit numb. Now, for some people who are profoundly depressed, I do sort of say to them, look, sometimes when you're starting the medication, if you're down here and we want to get you up here, there's going to be an in-between, not feel like if you're feeling really down and we want to get you feeling sort of good, there might be a piece in the middle where you just feel nothing.
Yeah.
But if we've come up from you feeling down, we're going the right way. So don't give up at that point.
Yeah.
Okay. But obviously, if you're not getting to the point where you're feeling better and the numbness is then having a negative impact, then yes, you have to review that. And sometimes you just need to look at what neurotransmitters you're looking at. There are different medications work in different ways. And again, in the background, you have the whole lifestyle and nutrition piece. But I'll sort of, if someone is very depressed and they come into you and they can't do anything, sometimes the medication just gets to the point where it's enough and they can start doing all the stuff. But I do agree with you. Again, it's so important that it's personalized. Like, what does this person want? What are they trying to achieve? What do they want to get from treating this with medication?
Yeah, and that may be one particular type of drug doesn't work, but that's not to say that a different type of antidepressant wouldn't work. Yeah. But I think what happens to people is sometimes they just get put off medication full stop if they don't get it right kind of first off.
No, exactly.
So it is.
And there's still that massive stigma around taking medication for your mood as well, and I can think back over my career, one that always stands out to me was this elderly lady, because we probably don't talk enough about depression in the elderly actually, but she was really quite depressed and we put her on medication, and her daughter was very anti-medication and had kind of come in and was not very happy, but this woman's life had changed on medication. I mean, she'd gone from being unable to function to being out and socialising and going to her active age group again. So I think, again, having that piece where you communicate with people, I think we've hugely moved away from that paternalistic point of medicine where you're lecturing and dictating to people. And as I said, that piece in the hospital where you're going to prescribe something, it's going to happen. it is a collaboration. You're working with the patient, you're talking to them, and you're reviewing them. You're bringing them back, you're checking in. And it's a really hard piece to walk, I think, because, you know, if you look at I probably shouldn't even say this, but if you look at the reviews from my practice, there are a lot of people up there giving out about us bringing people back and charging. And I get it, you know, that people don't like talking money in healthcare. And look, I would love if everything was paid for and we didn't have to talk about money. But I speak a lot to my staff about, we don't bring people back because we're trying to make money. Like, we're booked out, you know, we can fill those appointments. We bring people back because that's good practice. And if you start a treatment in someone, you should bring them back.
Absolutely.
If you've done a test, you should bring them back and discuss it. And it's about making sure that you've communicated the information, that you can hear from them, that they've had time to assimilate everything you've discussed. So I'm very particular about making sure if I've ordered a test on someone or started a treatment, that they're coming back to me. Because you're not going to get the benefit. It's a bit like, you know, I don't know, you get your hair done and they always say to you, if you're not happy, come back. You know, a lot of people don't, but you're not going to be happy till you go back, right? You have to follow up. It's important. It's good practice. And so I do, it's this piece of following up with your patients. And I love that I talk about being an owner-occupied practice. You know, I have 2 practices. I'm not looking to have 10 with the 2s. The second happened sort of organically. But I feel strongly about having a practice where people know you, where you know your patients, where they can come in and you know, the reception staff will sometimes say, so-and-so wasn't themselves. You know, they came in, they weren't just chirpy. That piece of just following up, and it is so important, isn't it?
Absolutely.
Because you're dealing with humans. And,
absolutely.
Yeah.
And just coming back to that piece then around impact on relationships, Nina, how, for anybody listening in or for watching, how might they make life easier for somebody who's actually experiencing ADHD? You know, if you're living with somebody who has ADHD, what might help that person?
I think it's understanding it, isn't it? You have to, you know, you have to understand the symptoms, because people with ADHD can be impulsive, and they can be, you know, some of them are louder than others. Like, one of the questions you ask is, are people louder, or they don't think it through, and they'll often just say what they're thinking without, there's no filter, so the word comes out. I think learning to understand, I think in some ways approaching every relationship like that is a good idea. You know, my husband and I joke, we got married quite young. We kind of say we grew up together because we learned to communicate with each other. And because of his ADHD, we had to learn to approach things in a different way, you know. So, you know, early on, probably we would have maybe disagreed about things, and we would have had arguments about things, because people with ADHD can get very, you know, if they feel strongly, they're going to verbalize that.
Sure.
So learning to create that space, learning to give each other a moment, learning to see the importance of thinking before you're speaking. You know, and funny, you learn, I think you learn communication in different ways. It doesn't even have to be whatever relationship you're in, whether it's with your spouse or a child or someone you work with. You can learn different things. And interestingly, as my children hit teen years, I remember meeting a psychologist at another conference, and he did a lot of child psychology. And he spoke about texting, you know, so say kids, quite often a good way to communicate with your teenagers, whether they've ADHD or not, is to text them, because it creates that space between the moment you speak to them, and they have to come back. And actually, so my husband and I would use that a bit in our relationship, is the texting, which I know sounds funny, but it's just, it allows you to take in, because obviously people with ADHD obviously don't hear very well sometimes. They can hear something completely different than what you're saying. So I think understanding, but that's not just an ADHD, that's in any relationship.
Oh, absolutely, yeah. But I think sometimes, you know, where those factors are a little bit more pronounced, and where people, as you say, don't understand, it can cause tension.
Oh, it can, because if you just take it from the way you expect, you know, if you expect everyone to behave like you do, think like you do, then you're not going to communicate well, are you? Because you have to understand. And I think that's a skill maybe you learn as you get older, is to learn from another person's perspective. I think it's getting harder. I think I think we live in a society that has become very introspective. So, social media maybe has done that. We're doing the selfies. We're focused on our social media. When we follow people on social media, we're kind of creating tribes, aren't we? You're going to follow someone because you identify with something they say or something they do. We're becoming really tribal. And I have to say, my personal opinion is maybe it's pulled us away from being a better community. I know we talk a lot about community, but the communities we follow are kind of our tribes. So if your community is only people who see the world the way you do, think like you do, have the same interests as you do, actually that's not community, because community is actually about people who have different perspectives on life.
Absolutely.
And we're becoming much more tribal in the way we do things. And we can see that, in my personal opinion, is we can see that at a global scale, where we have that rise of that very sort of far right, piece, right down to the tiniest communities where people are making all their decisions based on the influencers that they're seeing because they identify with something they say.
Yeah. That's so true, because even historically, there was so much of a community focus, and people breaking bread and growing vegetables and sharing them and whatever, that kind of focus, as you say, has become a little bit more on the individual as opposed to the collective.
And we're looking for, I remember, I think I told you before, I did some psychology when I was in secondary school, which just felt like such a lovely thing to do. But, I remember being really amazed by, the teenagers in the tribe. And it's so true, isn't it? Teenagers, they all want to dress the same. They all want to look the same. They all want to hang out together. And that's that tribal piece. But you're supposed to move beyond that piece to where you can look out of yourself to other people. I don't even know if there's research in this, but I don't know that maybe we're getting a bit more trapped in that tribe. As adults, we're just trying to find our tribes, and it's made us, I think, maybe a little not as good as at looking at things from other people's perspective. It's my personal opinion.
Okay, so in terms of, we're kind of coming to the close now, Nina, but in terms of things that maybe you're excited about in relation to the treatment of ADHD, what are some of those things?
I'm really excited as what we're going to understand about ADHD. I think we're going to understand a lot more the genetics behind it. That I find epigenetics fascinating. So it's that sense of the genes that you're born with. We used to think you're born with genes and you can't do anything about them. Epigenetics is obviously looking at, yes, it's the genes you're born with, but then genes are influenced by your environment, by stress, by infection, whatever that is.
Yeah.
I think 10 years from now, we're going to understand that much better. I firmly believe that there's going to be a huge piece about our environment and nutrition in that. And I think that is going to make us much better at treating things. I also do believe that AI is really going to help in our understanding of this, in drug development, in an understanding of neurotransmitters. And I would really love to think that we would have much cleaner drugs in the future, drugs that are really helpful without any of the negative side effects. I remember a psychiatrist saying to me years ago, there's no drug that has an effect that doesn't have a side effect. But I'd love to think that we could get so good at doing this.
Do you think we're close to that?
I think the speed at which we're accelerating is phenomenal. I think when I think of where we were when I qualified in medicine, it's 30 years this year, where we've come from in the last 5 to 10 years, like the rate of acceleration. And there's no doubt AI is playing a role in that. I mean, I'm really excited about AI. I think we need to regulate it. I think we need to be careful. But I think it's going to, in science, really help us.
Yeah, fantastic. So final reflection, Nina, is always with the guest. So for anybody maybe who might think that they possibly have ADHD, what might be some of the immediate signs, symptoms that you'd say to them, and maybe what to do?
So the word that comes to mind is overwhelm.
Okay.
So I treat adults with ADHD, okay? So if you're overwhelmed, if life is just feeling too much and you can't identify it, definitely go have a chat with someone, you know? And I'd listened to a few of your podcasts and I said you always ask this question, and I was in the car yesterday with my youngest son, he's 12, and we were going to school and they're doing their yearbook because he's 6th class and they all had to do a quote. And I said to him, what was your quote? And he had taken it from some South African DJ. Oh, I forget his name now. But it was, there's always a reason to smile, you just have to find it. If you're struggling to smile, if you're smiling with your ADHD symptoms, you don't need anything done.
Happy
But if
days.
you're struggling,
Yeah.
if you feel you have these symptoms and you're struggling to smile, it's stressing you, go talk to someone, because that
Okay.
means the impact is there. Yeah.
Okay, fantastic. Dr. Nina Byrnes, where can people find you?
So obviously the clinics are Generation Health, and so we have a clinic in Castleknock in Dublin and in Monkstown in Dublin. And I'm on, I still love to call it Twitter, but it's now X, isn't it? Nina Byrnes, and Instagram then. So I did have a personal Instagram, but we have a new work one, so it's Dr. Nina Byrnes. And yeah, I'll be on there.
Fantastic.
And I have to do my 23-year-old daughter is much better at social media than I am, and she's on to me to do TikTok. So I guess that's coming. I just haven't done it yet.
Okay, so that's
Yeah.
in the pipeline.
Yeah.
Fantastic. Dr. Nina Byrnes, it's been an absolute pleasure, and thank you so much for joining me here and for coming from Dublin. It was really great to have the chat, and I know a lot of people will, take so much from what you've had to say, and thanks again.
It was a pleasure.